Hello everyone, so today we'll talk about another cardiovascular disease, the famous one called angina. Right, so angina is just one of the names because there's a lot of subtypes like myocardial infarction, right, those ST elevated ones or non-ST elevated ones. So basically it refers to the common term of heart attack. Right, so what does it mean by it? So basically it refers to the imbalance of oxygen demand in the heart. So heart per se, although is the organ that supplies all the blood, all the nutrients and all throughout the whole body, but the heart per se also needs its own blood supply as well. So this refers to an imbalance of the oxygen supply within the heart itself. So that which then could then lead to the death of certain cells in the heart, like the cardiac myocytes, like the muscle cells in the heart, which could then lead to the death of the cells. Right, so when some of the cells are dead and so on, so obviously the heart function would be affected as well because there's reduced number of healthy heart cardiac myocytes that could do the pumping of the job. Right, so basically what happens is when, as you see in this balance, whereby the oxygen demand is more than the supply. Right, so there's a few main determinants of myocardial oxygen consumption demand. So it depends on the workload of the heart in general, right? So if there's a higher heart rate, a higher contractility stimuli, so which then causes an increase in the requirement and increase of work required to be done by the heart. So obviously the heart will then need more nutrient and more oxygen to support the function, right? So the class overall defines the basics of it, and obviously we'll go through the drugs of it as usual. So when you look at the drugs which are involved, so you can see there's one main group which has not been touched on by in other topics, which is the nitrates. The others is already been mentioned in other classes. So do bear in mind if it's the same drug, the mechanism of action will still be the same, but the hemodynamic effects that we'll look through that causes the positive therapeutic effect that you want would be slightly differ between diseases. Right, so how can it occur between the imbalance of oxygen supply and demand? So there's normally an increase in the supply, right? So sorry, not increase in the supply. Let's look at the supply part and the demand over here. So supply meaning whatever that goes into the heart organ per se. So we normally look at the main arteries, which are and for the heart, right? So there's three main ones over here, as you can see: the right coronary artery, the left anterior descending coronary artery, the left circumflex coronary artery. So these three are the main ones. So bear in mind if there's any blockage as well that happens, or arteriosclerosis that occurs between these three main arteries, so then you affect quite a huge part of the cardiac myocytes to get cut off of the oxygen supply, which then causes death of the muscles as mentioned earlier on, right? So i.e. the perfusion of the heart will be affected. So these are the three main ones. So again, these three main ones are the ones which are looked through more thoroughly during the angiogram, if an angiogram is being done, right? So another part is the demand. So demand, as mentioned, depends on the workload. So as you can see here, so depends on the preload, the afterload, which then determines how much stretch is needed for the heart in a way, right? So let's look at the arteriosclerosis. So there's a few terms which are available as mentioned in the first slide. So angina is a very general one. There's a few more that will be mentioned here. So arteriosclerotic plaque actually depends. It's not that once the plaque is formed, it will cause a huge problem. No, it depends on the size of it, of course. So it can be the plaques have two main types. The first one is the more oily fatty type, which is mainly cholesterol based, which is more easily treated in a way or prevented, because as long as you control the plasma cholesterol level, and details you can find in the hyperlipidemia class. So basically, if you can reduce the amount of circulating LDL in your blood, you can reduce the formation of this arteriosclerotic plaque. Right, but the thing is, there's another type which is the calcium type. So that is the one a bit more tricky because you don't really have drugs that can target it at the moment. Right, so and they're harder, they're more stable, they're not easy to break off. But then it's not that easy to, it can't really clear it through medication. Right, so for the current moment, so it can be asymptomatic first, then later on it forms bigger and bigger over time, and this could take years and years, bear in mind, right? Okay, and there's something that I'd like to remind you all as well is that when you look at cross sections of the arteriosclerotic plaque, i.e., of the cross section of the blood vessel, we always give people the implication that the plaque is only formed at one part of it. But bear in mind that in actual fact, the blood vessels are like a piping, isn't it? So the piping is long. So the plaque can be throughout the piping, but at certain places it can be at a thicker deposit, so meaning there's a greater block at certain sections compared to others. So the percentage of block is determined by the one which is highest blockage location, if you get what I mean. So yeah, so if there's, so imagine there's it's like a piping and inside is uneven surface. So the section of the surface which has the narrowest part, so that will determine what the percentage of block is it. Because once there is block, I don't care whether, I mean, it doesn't matter whether the other parts are fully unblocked or not. The supply is already being blocked as long as there's one gate, i.e. Right, so as mentioned in the early slide, so this is stable angina. So it's a stable plate. So it's a reduction. So normally in stable angina, as you can see, is there still blood flow? Yes, there is. Right. So, but it's a lesser one, of course, compared to the unblocked version, right? So meaning if the heart is not under increase in the demand, so it's not that when the person has to do extra strenuous activities like exercise and so on, the amount of blood supply, although it's lesser, but it is sufficient to support the activity. But once if there's increase in activity, right, when a person needs to go for a walk, or not for a walk, like for a huge run suddenly and things like that, or there's suddenly an emotional surge, right, where you, i.e. there's increased workload of the heart in a very sudden way, then there could be insufficient blood flow, right? So this is when the pain in the heart, a pain in the chest might occur. So the pain actually in the heart attack literally means that the body, there's some damages in the heart muscles already, in the cells. So it's our natural protective mechanism to ask us to stop the activity that you're doing. So that's why there's pain reflux over there. There's a trigger of the pain by the release of certain chemicals or chemokines. Right, so in general, when we look at it in the more severe version, it's actually called acute coronary syndrome or ACS. So when you look at guidelines, it's actually divided into all the subtypes. It can be the unstable angina, whereby the plaque is not very stable, so it ruptures and floats off parts of it. They can be the non-ST elevated MI and ST elevated MI. So the difference is based on the severity. So when you look at it, as you can see, the non-ST is less severe compared to the ST, right? Because once the plaque is cut off, so again our body thought that, oh, there's an injury that I need to stop the blood flow. So you can see the blood clot will then form on top of it, which then further blocks the blood flow because the space available is getting lesser and lesser. So for non-ST elevated, so the ST refers to the PQRST in the ECG, right? So meaning if there's non-ST elevated, so meaning it's not that severe, you don't really change the ECG of the heart. So when there's ST elevated, so meaning there is more severe damages in it, right? So that's why, because the blood flow is totally being stopped, so there's some actual damage which already occur, therefore resulting the changes in the ECG of the heart. So this is just to show you the lipid rich and the soft ones are more dangerous because they are more unstable. Right? So clinically, as mentioned, all these diagrams again is from the newer guideline, right? That again, you're strongly recommended to read through, to go through the guideline. So ischemic chest discomfort, again, as mentioned over here. So you got unstable, ST, STEMI, or STEMI per se. Right, so for treatment, as mentioned just now, so either you can reduce the oxygen demand or to increase the supply. So it depends on which one you want to go through. So how can you reduce the demand? Obviously, it's reducing the heart rate, reducing the contractility, and so on. So what you can do is you can actually give some CCB or beta blockers to reduce this section, right? So, or you can actually widen up the vessels, so by using vasodilators and things like that to increase the supply. So management, as you can see here, it's actually involves multiple different drugs from different angles. So here we'll go through the guidelines very briefly for different types of it. So this is the stable CAD. CAD relates to coronary artery disease, right? So you can do symptom control. So this is the first one, so which is the nitrates that we're going to go through. And we got the beta blockers and CCB again. So if it's not so well controlled, you can top up with different types of drugs again. So bear in mind there's short-acting nitrates and long-acting ones, right? And there's also prevention. Again, you have to stop the further progression of the overall disease. So you again have to control all the risk factors like any other cardiovascular diseases, like hypertension and so on. Right, so we've got the STEMI one. So you can see the secondary prevention refers to what should you do to protect the person from the second attack, heart attack. So again, you can see the points are just repeating by themselves. So again, you've got non-pharmacological lifestyle modifications like smoking, exercise, and you've got your drug therapy like antiplatelets will be coming in. So but details you can see in the other classes, right? So which I'm going to record later, right? And obviously compliance, ACE inhibitors, and so on, right? Next. So we'll go through this is what happens in the clinic. So obviously, as mentioned just now, the more severe one or the more dangerous one is the STEMI, because there's changes in the ECG already, right? So there's actually a very short time frame of what you can do to reverse the condition completely, right? It's also mentioned in the recent guidelines. As you can see, the onset of symptoms, the way you can treat it actually depends on when it happens. So in a way, if you should tell the patient, whenever it happens, the first thing is, besides taking your short sublingual GTN, if you can see over here, or if you get aspirin or whatever, just try to take some of it. And also to look at the time and when you need to go to the hospital, because again, time is gold, time is hard. I think there's a golden saying here. Okay, because the longer it is, so certain treatment will be less effective, right? So that's why there's a certain classification of what you should do at certain time, right? Again, details you can just go through and remember the management of this STEMI actually involves different modalities. As you can see, there's antiplatelets or anticoagulants. There's also cholesterol drugs as well, and things like that. So do bear in mind you have to combine your knowledge for different classes to understand the whole treatment modality. Right, so level of evidence, again, just to show you. So what can you do? So aspirin will be at least 75 to 150 mg daily. It's like a baby dose aspirin. You can top it up with clopidogrel, right? So if the person has to go through angioplasty, meaning i.e. the normal common term of adding a balloon-ish into the vessel, right? So that one you actually need to give together concomitant with a year of clopidogrel. Right, so again, details you can find in other classes, right? So it can be, if the person cannot tolerate clopidogrel or is ineffective, then you can actually have other options as well. And don't forget there's beta blockers as well. So when do you need to do it? So in some patients, if they already have reduced heart ejection fraction, i.e. there's a little bit of heart failure, so you actually need to give them for longer term rather than the shorter term one, right? So again, can just go through. So I'll just focus a little bit more on the pharmacology section. So here we're looking at the nitrates. So nitrates in general, what the magic refers to the ability of the drug to actually release nitric oxide molecule, which can causes relaxation of the vascular smooth muscles. Right, in this case, we are focusing on the vascular smooth muscles of the heart vessels, as you remember just now, the arteries that we talk about, right? So again, NO, which then activate guanylyl cyclase, which then activates all its downstream to cause the activation of the phosphatase to dephosphorilate the myosin light chain to then cause relaxation. Nitric oxide is also a natural occurring molecule in the body. So how is it being formed normally? So this is, I don't really need you to remember all the details, but I really need you to understand this part. Okay, it's actually an interplay between the endothelial cells and the vascular smooth muscle cells. So the endothelial cells will actually release NO, right? Which then causes the downstream relaxation of the vascular smooth muscle. So there's a few players here like enos and so on. Right, so what are the hemodynamic effects? So what happens? So this one is something that you have to follow with me a little bit closely. I hope I can explain a bit better this time, because the last round when I explained this, I think I explained some parts a bit wrongly. So I've got some questions after that. Right, so what is the effect of the nitrates, NO? How does it happen? So it exerts at different parts of the vascular system. So the first one, as you can see, as you can read that the text here as well, it mainly acts on the venous capacitance vessel. So it's actually at the veins over here. So when this is the capacitance vessel, so this is the first action point. So this is based on the concentration dependent. So meaning at the lowest concentration, the main effect is on the vein and the veins. Okay, so when there's increase in the vasodilation, so there's more pooling of blood in the veins. So there's not so much, but sorry, my boys, very excited. Okay, so there's not so much blood that will go back into the heart at the same time. So there'll be reduced in the preload. So there'll be less responsive contractility after that. So therefore that it reduces oxygen demand. Right, so later on at higher doses, however, it can also affect the artery section. Therefore it can reduce the afterload. So and bear in mind there's also another part here whereby you can also the nitrate will also act in increasing the oxygen supply by dilating the large epicardial arteries as well. So when you increase the vasodilate here, so there'll be more blood flow through the half-blocked arteries that I mentioned just now. So there'll be more blood supply to the heart cardiac myocytes, the downstream cardiac myocytes at that area. Right, so increased venous capacitance, So bear in mind, so again, our body is very clever again, so it could result in reflex tachycardia. Right, so that's another reason why we do not overload the patient with too high concentration of organic nitrate drugs, because again, when the whole system slows down, it can have reflex tachycardia, which then reset the system back into normal again. Okay, so another part here that I would like to mention is about this one. The main effect is actually on the large epicardial arteries, which is pretty important, right? Because you want the effects to be on the large arteries rather than on the smaller ones, because if it's on the smaller ones, they'll have this coronary steal phenomenon. So what does it mean by that is that if the effect, but it's not happening, all right, but the effect, if it's more on the smaller arteries rather than the large arteries, again you have pooling of the blood at the smaller arteries, which is what you don't want, because you want to dilate the larger arteries so that they'll have more blood through all the small ones downstream. Right, so there's also some effects as mentioned just now at larger doses, so they can cause a sudden drop of the blood pressure, like refractory the hypotension suddenly, reflex tachycardia, some dizziness and so on. So therefore, based on dizziness and headache, flushing, the main thing that you need to do is when you want the person to administer organic nitrate drugs, the first thing that the person should do, again also to reduce the activity and workload of the heart, is that the person needs to sit down. Okay, obviously don't just walk around and so on, because one of the reasons is that but after administration of the drug, the person could experience dizziness as well. And you don't need a person to experience another fall on top of whatever heart attack, heart pain that the person, chest pain that the person is already experiencing. So details you can look through over here as well, the beneficial and the not so good effect of nitrates. So again, the main, it's not nitrates that is a bad drug, but you just need to know how to use it properly. Right, So, example of nitrate drugs. So, you remember just now we talked a little bit about the short-term and the long-term differences. So, the one on the left, which is called in short form, we call GTN, which is glyceryl trinitrate, is the short-term one. And yes, the longer-term one of the which is over here, which is called isosorbide dinitrates. So you've got isosorbide dinitrate (ISDN) and also isosorbide mononitrate (ISMN). Right, so you can see based on the structure, they're all very simple structured drugs. As you can see, the main thing is it for the structure that is you need to release the organic nitrates to form NO in the body. Right, that's the main purpose. So all this is done in the liver. Right, so this is how fast the drug could act. So in this one, the short-term one, the half-life is just 5 minutes. Again, you need something which can act very quickly so that it can save the patient by having very quick vasodilation response, so that there's not so many heart muscle damage, right? Then the person can go while waiting for their time to go to the hospital or waiting for further intervention, like anticoagulants or antifibrinolytics or angiogram or angioplasty could be done. So this is some short-term relief, which is very, very important. So there's also the resulting molecule has a longer half-life. So isosorbide dinitrate is 1 hour, 2 hours. The longest one is 4 hours, which is the ISMN, right? So it quickly undergoes glucuronidation in the liver and excreted renally. Right? So what you need, as mentioned just now, to prevent the tolerance level to be formed, you need high doses and periods with low nitrate levels. Right? Okay, so this is examples of other nitrate drugs. This is nitroprusside. So, but nitroprusside is not really used, but sodium nitroprusside, yes. So it's something that you can use IV form if the person is in the A&E department. Right, so again, because it's in IV form, you can obviously titrate the dose very carefully, right? You can use during obviously emergency as well. Okay, so there's some toxicity and so on, but don't worry over too much about it, because again, these drugs are just to be used for a very short period of time. Okay, so here, as you can see, there's a few of it. Again, to show the dosing and so on. So some details that you can go through. So do know the differences, because then you'll determine when you should use which one. So GTN is the fastest acting one, as mentioned. So it's mainly you need it to be at sublingual, because remember there's a lot of blood vessel supplies under the tongue. So therefore, once upon absorption and all the drug molecule can quickly travel to the liver and then travel back to the arteries, which is the nearest. So which is near to the blood vessels, arteries, and so on, under your tongue as well. So you need to be under the tongue. So therefore, there's you can imagine there's quite a bit of counseling that need to tell the patient. So basically, it's a Superman drug, I like to call it, because the effect is really, really quickly, but you need to use it correctly. It's not a drug that the person should chew quickly and to swallow it. No, just have to stay calm, sit down, stay calm, put it under your tongue, and look at the clock, because every 5 minutes you can take it up to two doses. By the third dose, if the person is still experiencing no difference or no better in the chest pain, you start to call the ambulance already, right? So again, because remember the molecule just now from the structure, it's a very small structure, so it's not that stable actually. So it's a very volatile molecule, so you actually need to keep it in a glass container, protect from moisture and light and so on. So basically that translates into a lot of practical points, such as you should not transfer the molecule out into the normal whatever plastic medicine container, plastic bag, the medicine bag. You shouldn't just put some cotton bud on top of it so that to prevent its sound, because when you put it in the glass container, it's cling clang, there's a lot of sound out of it. You shouldn't be in extremes of temperature. You can't just keep it in the car, because Malaysia temperature is just way too hot. Keeping it in the car will just cause all the molecules to be just gone. Okay, so they could experience a bit of burning sensation, but it doesn't mean that if there's no drug inside there anymore. right? So you can actually use, the person can, if the person is having stable angina, sorry, so you know that always after exercise there'll be a little bit of chest pain, you can actually use it prophylactically before the activity, the strenuous activity. So yep, so again, maximum 3 tablets over 15 minutes, so meaning 1 tablet every 5 minutes. If it doesn't relieve, time to move to the hospital, right? So it can be oral form, so all this is quite long in a way. So these are the ones that we're talking about, the longer term nitrate drugs, right, like ISDN and things like that. So and ISMN, right? So again, the effect is a bit longer, right? So and there's also metabolites. So what the main point that I want to point out here is that you try to administer it about at least 7 to 8 hours apart to prevent the tolerance from being formed. And there's also another easier way to do it, is actually through the patch way. This is less commonly used, but it is available in the market, right? It can be an ointment, and again, you need a few hours apart to apply it, right? So you can use it for nocturnal angina, right? So again, it's a slower absorption that you can do it. So again, you have to give them time before the next dose is being applied. So transmucosal and so on. So you can just read through. So what the contraindications, to find out about it. So based on the latest guidelines, so these are some of the doses which is mentioned here, so which can use as a reference, so hopefully it'll be useful for you. Right, so another part is the CCB, which is something that is mentioned in the hypertension class already. I already uploaded the slides as well, and the recorded ones, right? So so again, as mentioned, if you can still remember, so we've got dihydropyridines, and the main one that we're looking at is the CCB that acts on the heart, which is the verapamil, and also a little bit about the diltiazem, which actually acts both on the heart and also on the blood vessels. So you can see the selectivity scores over here. So basically, you just want the heart rate to reduce, heart contractility to reduce, reduction of the conduction, the speed of the conduction, electrical conduction of the impulse over throughout the heart, and so on. Right, so details you can find over here. So basically, you can act on different parts of it. So again, the main part is vasodilation as well, right? So vasodilation of the coronary arteries over here, right? And also, as mentioned just now, the other parts. Right, so you need to know when to use. So this one is another diagram which is quite similar, right? So I'll just go through, just fly through in a way, because again, it's very similar. So again, all this, we try to reduce the oxygen demand in the heart again, and to increase the supply of the blood to the heart, right? So you do not try, normally we don't try combine it with beta blockers, again, because there's a lot of similar in the action between two drugs. So we don't want an over reduction in the heart rate in case we stop the heart, right? Okay, right, so there are some other relative contraindications, you can go through them. So what are the side effects, go find out. So this one again, you can go through as well. Okay, so this is just to remind you, there's also ACE inhibitor and things like, which is indicated under STEMI conditions. So this is from the STEMI guideline, right? So again, you can start to give them within the first 24 hours if they're high risk. But normally, unless they're first time, they didn't know anything that they actually have this underlying cardiovascular disease. If not, you probably expect the person to be already on ACE inhibitor actually, because obviously you can use it for hypertension and so on. Right, so there's some ACE inhibitor or ARB which are indicated for STEMI, as mentioned over here, so you can look through them. So these are the more popular options for the patients. Again, there are some beta blockers as well that you can use. So there's some initiation dose and target dose, and bear in mind, not all beta blockers can be used. Okay, so beta blockers, as mentioned, is quite as usual, reduction in the heart rate, which then causes reduction in the blood pressure and contractility. So again, we want to reduce the myocardial oxygen requirement, right? So again, almost all types can be used in a way, but the three main one indicated are these ones. So there are actually other three more anti-angina drugs, right? So we'll just go through. Just putting down here like a preview, just because these three drugs we haven't seen them before, and it's quite special because this is like one of its own in its class. Sorry, before I forget, I thought I just remembered something about the Superman GTN that I forgot to tell you just now. It's about obviously you try not to call and use the Superman all the time in a way. So meaning there's a lot of episodes of emergency. So if the person is using it more frequent than usual, then it's also an indication that the person should also go to visit the cardiologist very soon, because the condition is not very well controlled. There's worsening of the condition, right? So always do not rely on Superman to save you all the time, in case one day he might be busy, or i.e. the drug has developed tolerance towards it. I mean, the body has developed tolerance towards the drug. Okay, so back to this Nicorandil. So Nicorandil is a new drug basically it's a drug by its family as well. So we're not ultra sure how it works. It's a very old drug, as you can see here. Not the most popular option. Oh, excuse me. So there's a bit of nitrate-like action. There's a little bit of action on the potassium channel. So basically, it's a potassium channel opener. So yes, it can be used for a stable angina as well. So it's not very popular because it causes some weird side effects of ulceration in the mouth. Super weird, but thank goodness it's reversible after withdrawal of the drug. So there's another one, ivabradine. So this is also interesting because it's initially developed for people who cannot use beta blockers. So basically like asthmatics and things, so they cannot use beta blockers. So what are the other options that can go for a similar therapeutic effect? So something which is called ivabradine. So this is selective towards this IF sodium channel blocker. So what happens is that it reduces the heart rate only. It doesn't affect the heart contractility. Very, very specific effect on the depolarization slope. So it acts on the SA node of the heart, right? So again, you can use it for heart failure and angina. Okay, so yep. So not used that much now. You can find out the trial about it. So it's not that you can find out about a trial and let me know how do you think about it. Right. So another one which is ranolazine. So it's a little bit more popular. It's a newer one. So for this, the mechanism of action is a bit tricky and interesting. So we'll go through bit by bit. So what happens is that it actually works on the sodium calcium exchanger. Right, so they suspect what happens is that during a cardiac ischemia, the ROS and all basically causes a lot of influx of sodium into the cardiac myocytes. So a lot of influx of unwanted sodium, literally. So and over here, beside all this sodium channel, there's this sodium calcium exchanger. So as mentioned from the name exchanger, so it goes in and out. So what happens here is that 3 in conversion with 1 calcium. So you can see the charges are not even, they're not equal. So there'll be a difference. They'll cause a net changes in the charge. So what happens that when there's a lot of sodium influx into it, so our body will try to get rid of it. So when it gets rid of it, so again the sodium has to go out. So in exchange, the calcium will actually come in. So therefore, you can actually cause a lot of calcium entry, so there's more contractility in the cells. So if you blocked it, right? So if you block it, so you manage to block the so the ranolazine will basically block the sodium channels. So when you block the sodium channels, you reduce the excessive influx of sodium, which then reduces the excessive calcium accumulation, right? So therefore it reduces the contractility. So details you can look through over here. So in short, it reduces the calcium overload. Right, so again, like any like hypertension and so on, you can actually choose the drug based on the comorbidity of the person is experiencing. So again, you can just refer to the chart over here as well. So again, you can use combined therapy as well. So it's also very common to use nitrates with calcium channel blocker or beta blockers. Right, so because it'll counteract the reflex tachycardia, remember, yeah, so that will be nicely being inhibited by CCB and beta blockers. So bear in mind if it's in the hospital upon emergency when the person is admitted. So this is just to show you the interplay and the role of different drugs in the whole chart. So we mentioned a lot about other sections already, but here I'm just trying to mention the part about opiates. So obviously in extreme pain, our body is also in a lot of distress. So opiates will, in this case, will actually reduces the pain to calm the patient down. Besides reducing the pain, obviously it has a calming effect as well. To then reduce the heart workload as well. To then overall to steal some time to actually prevent more myocardial damage, right? So this is the final slide, which then summarizes all the mechanism of action at different parts of the heart. Thank you. Have fun revising.